I think no seminar is complete without at least talking about, DVT prophylaxis and risks of VTE, which is, venous thromboembolic events. So I think just want to touch base on some of the newer medicines that are out there. I put I invented Eliquis, which is not true. I have no financial disclosures, but there are brand medicines that will be mentioned in this lecture. I just have no stake in any of them. So why do we debate? Well, here's a good example. There was a survey study that went out in Foot and Ankle Specialists in 2015 to a bunch of different surgeons, orthopedic, of all different ranges, and podiatrists, I should say, asking about specific cases and scenarios and whether or not they would prophylax these patients after surgery. And they got an array of answers. 56% in case 1 said they would, 97.5% said in case 2 they would, and in case 3, 49% of them said they would. So it creates kind of a need for some standardization, right? We have to kind of come up with some kind of protocol here. Now, when we're talking about VTE, basically it encompasses deep venous thrombosis, superficial venous thrombosis, which sometimes you'll see on an ultrasound. A patient may have lateral leg pain after a surgery. I've had this happen to me. They have an ultrasound that shows a clot in the superficial vein that's close to a deep vein, and it's treated like a DVT. It's a venous thromboembolic event and needs to be treated, or pulmonary embolism. And we have an array of different kind of medicines and mechanical methods to kind of combat and prevent these things from happening. It's the number 3 cause of death, in the United States. 60 to 100,000 Americans die annually. It's the number 1 cause of unexpected death. So, autopsies pick this up. When we talk about incident rate, there's a lot of different studies out there that talk about incidence. Obviously, this is one of the more recent studies that I found, looking at it in regards to foot and ankle surgery. And incidence rate is low. 1.2% is pretty small. That's higher than an infection rate, and we give prophylactic antibiotics before surgery almost all of our patients. So if you're talking about it in regards to what you're going to do to protect your patient, through the perioperative process, this is a little bit higher than what our standard infection rate was, and everybody prophylaxes for, or most people I should say, prophylax with antibiotics to prevent infection afterwards. Again, looking at survey highly, now looking at some, congruency with everyone agreeing on prophylaxing patients afterwards in certain scenarios. So the pathophysiology of a DVT, what is it? We go back to our medical textbooks and talk about Burchard's triad, which is basically 3 different factors that kind of come into causing a clot or causing thrombin, basically through vascular damage, different factors in patient's blood that causes them to coagulate, and then the slow flow, usually in legs, where the blood is stagnant, and then that can cause it to coagulate and cause a clot to form. Another kind of thing that I kind of came across in my hospital system, and I think that this is kind of happening kind of everywhere with bigger hospital systems, is looking at what's called an enhanced recovery after surgery protocol, or ERAS protocol. And these are standardizations that go across multiple specialties, where they're looking at preoperative risk factors, looking at the type of anesthesia that patients are getting, how long cases take, intraoperative strategies, things that can be done in the operating room to help reduce the risk of VTE, and then giving guidelines on postoperative care and discharge instructions. Nowadays, we're on Epic, and the discharge paperwork that a patient gets from a bunion surgery is 16 pages long, with the one page that has my notes in it that I really care about, and then everything else that they probably don't read. But there's a lot of things in there about signs and symptoms of DVTs and VTEs, and it usually stems from basically your ERAS protocol, or your enhanced recovery after surgery protocol that your hospital system and your medical boards will kind of collaborate on. So it's something just to be keep in mind. Another thing is risk assessment. So risk assessment, looking at patients, and this is part of actually my hospital's EROS protocol, is the Caprini risk assessment tool. And this is something that they started asking the doctors to fill out on behalf of the patients prior to surgery. And when it first came out, you're trying to get into an operating room at 7:30 in the morning, or they're at 7, and then they give you this whole list of things you want to try and fill out with the patient, and then wonder why you're not running on time. But this is something that can also be filled out prior to surgery. It's a website, CapriniRiskScore.org. Patients can do it to evaluate their own risk, or you can do it to evaluate your own risk, or as a healthcare provider, you can do this with the patient in the office or preoperative setting to kind of get an idea of what their risk factors are, what their risk scores would be, and then that can correlate to the proper treatment protocols for afterwards. So let me see if this started. Oh, there we go. So this is just a video of me on the computer, going through all these. So these are some of the questions that they ask. Basically, whether it's have they had surgery before, do they have varicose veins, swollen legs, heart attack, in the past month, any type of serious infection. It kind of goes all the way down, and then if you can just click to the perfect, yeah. So and then you get at the end of all these questions, you get a summary, and I know it comes up a little small there, but basically it's just looking at the red is all the things you said yes to and what the risk factors are, and then it gives you a score, and in this case the score was 10. So where does that fall in regards to the patient's risk of developing a VTE? Well, they're put in a certain category where they're considered high risk, and that the recommendation is to anticoagulate or give prophylaxis afterwards. Now, this was generally for hip replacements or knee replacements, some of these bigger orthopedic procedures, but it is a way to get a guideline of knowing what risks your patients are taking on prior to surgery. Back in 2013, before this Caprini was brought up, there was a JFAS article that looked at risk factors, and they had a similar scoring method. And so I would, with this lecture, tell patients to get tell the audience members to take their phones out and snap a picture of this so that they can have it easily accessible, with my little snap a guy here showing some of these risk factors, and then obviously looking at their scores. Now you're going to look at this graphic on the bottom and say, whoa, a 5 or more, they have a 40 to 80% risk of a DVT. No. What this kind of showed is that patients that ended up with a DVT, 40 to 80% of them, that had the DVT had a 5 or plus score. So you may not get a DVT if you have a score that's 5 or higher. You may, and it gets lower as the score gets lower. But when patients did end up with a DVT, this also showed that this was the kind of range that they were in of having these risk factors associated with it. So it's important to kind of keep in mind. Another risk factor that I think we can't get kind of away from yet is COVID-19, an inflammatory disease that obviously affects multiple systems. And there was a study that came out this year that showed that there was a 2 to 3-fold risk of venous thrombosis, whether it's DVT or pulmonary embolism, after a COVID-19 infection or even after a vaccination. This was my patient in January. I had a 68-year-old lady who had 0 risk factors, healthy as a horse, took no medication. 12 days post-op, had bilateral pulmonary embolism. Woke up in the middle of the night, shortness of breath, called 911, was taken to the hospital. She had an Austin bunion and a second toe repair. Weight bared right afterwards, no prior surgeries. Obviously in New Jersey we have our medical clearance is done by our primary care physicians. Cleared her. There was no problems whatsoever. Ended up going to see a hematologist afterwards because she obviously was hypercoagulable. There was no other diagnoses other than she had a provoked VTE event from bunion surgery. But she did mention to the hematologist that 3 days before surgery, she had her 4th COVID booster. And, basically, from there, it was kind of, well, it could have been a mitigating factor. It's hard to say right now with the way the studies are. But, that's just another thing just to kind of keep a lookout, and brought a lot of attention to me because, that's the first time I've ever had anyone have a PE, and it was, one of the, simpler weight-bearing procedures that I didn't prophylax on. So when we talk about prophylaxis, we're talking about using medications, drugs, along with mechanical methods, and the combination of those is basically, determined by the postoperative risk factors, how invasive the procedure is, again, how long it is, what kind of anesthesia, whether it's general anesthesia or local MAC, and then the patient risk factors that we just discussed. Mechanical methods would be, using TED hose, compression devices on the patient's contralateral limb, whether it's foot or leg, during the procedure, and then seeing how they are moving around afterwards. When we talk about these medications, we're kind of looking at the process of hemostasis. Is the kind of the opposite of what a clot is, and there's 3 different components to hemostasis, and we have medications that work on all these processes. And so, with a lot of the medications that we use for VTE prophylaxis, we're affecting what's called the clotting cascade. So, I don't want to get into a big biochemistry lesson here, but the clotting cascade, in a simplistic view, is 2 components: the intrinsic factors, so they are the ones that are circulating inside your blood vessels, constantly, always there. And then you have your extrinsic factors, which are activated from injury. So have surgery, fracture of bone, when you cut through tissue, those factors get activated and they mix in with the intrinsic factors to make the common factor, factor 10 or factor 10A. And then eventually it comes down to thrombin. Thrombin is the main, ingredient to creating a clot. There are tests, obviously, that look at, these factors and how well they're circulating in our blood, our PTT and our PT-INR, looking at them, and then we have medications like heparin that work on and against the intrinsic pathway, and Coumadin, which kind of works along, all of them. So warfarin or Coumadin, it affects, coagulant factors across the board, basically because it stops your liver from producing them. That's kind of why they take 7 days to become effective. Basically the ones that are already in your system are already floating around. They're going to go through that process, but Coumadin will stop your liver from making new ones. So once they've already kind of worked their way out, then you can become clinically anticoagulated. Coumadin, is affected by a lot of different drugs. One thing that I always kind of point out is that if a patient's on antibiotics and they're on Coumadin, it may have an enhancing effect, causing their INR to go up. Alcohol is another big one too, because again, metabolized through the liver, we're losing some of our metabolites when you drink alcohol. So now the Coumadin may not or may be processed a little bit faster. And then there are decreasing effects, medicines that'll actually work against it. And then foods that are high in vitamin K. Vitamin K is an antagonist to Coumadin, and so that sometimes will prevent your INR from becoming therapeutic. It'll cause it to stay low because vitamin K goes through your liver. It helps you make more coagulant factors. So again, these are all the disadvantages. Certainly with Coumadin, food interactions. Initial strict monitoring, obviously getting an INR every day on a patient, making sure that they're therapeutic or they're not too over therapeutic as well, and then require bridge therapy. Bridge therapy, it's a use of fast-acting anticoagulants, usually through injection, sub-Q injection, to anticoagulate the patients quickly while you're also taking Coumadin until their Coumadin levels are at a therapeutic level, which is usually between 2 and 3. Now, when patients are on these, on Coumadin, the other thing you have to kind of look at is, can you stop it? So preoperative planning is certainly a big part of this. If they're on Coumadin for chronic atrial fibrillation, mechanical heart valve, or they've had a prior VTE, is it okay just to stop it cold turkey 5 days before surgery? Or do you have to actually bridge them with something, to keep them protected until the day of or the day before surgery? Then you can stop everything and then get their INR level back up afterwards when there's no risk of bleeding secondary to surgery. So there's a lot of risk stratification that goes into this. That's usually used with, in conjunction with your cardiologist or internal medicine doctors, to make sure that you're protecting the patient, through the entire, perioperative period. So then comes along direct thrombin inhibitors. A reason for new therapy is kind of the, where this came about. And thrombin, like I said, is that main factor that makes a clot. It's got 2 receptor sites. Now we have medications that can attach to that and kind of stop that process from happening. One of the first newer agents was Pradaxa, and Pradaxa really is used more for atrial fibrillation and for some irregular heart rhythm reasons, and also for treating VTEs. So you may not see a patient, or you may not use this on a patient to prophylax them, but this may be a medicine that they're on, and where that comes into play is that you don't need to prophylax them, because when they go back on that medication after surgery, they're protected from any problems with their atrial AFib, as well as being protected from any VT events, because they're already anticoagulated with with this. There was a study that looked at using Pradaxa versus using Lovenox, the Renovate Remobilize studies, and it showed that it was very equivalent as far as protecting patients afterwards. So it worked very, very well. Dosages, for patients for VTE prophylaxis, 110 milligrams. It's a once-a-day medication taken orally. Sometimes it is bumped up to 150 milligrams BID for high-risk patients, meaning patients who have, non-valvular atrial fibrillation, or they've had a history of a VTE prior. The RECOVER study, this was a study that compared Pradaxa to Coumadin, and where this was kind of interesting is that it looked at patients who had a DVT and how they were treated afterwards. Certainly if a patient, came in with a VTE and they had to be treated for it with Coumadin, you have to wait until their INR is up to a therapeutic level before they can be discharged, or have to have a protocol where they're bridged until they, on a heparin drip or something like that, until they have Coumadin levels. With Pradaxa, patients were given it, and 24 hours they're able to be released from the hospital safely, being treated for the DVT. Another subset of medications, which I think we're going to see more of these, and this is kind of what I use as far as my oral options are the factor Xa inhibitors. Very similar to the medicines, they just work on a clotting factor that's a little bit higher up than thrombin. One of the reasons why these are very, very useful is they don't interact with anything. It's very rare that they would have any food interactions or any other drug interactions, and they're very effective, right after surgery. So you can kind of time when you want to use them and know that the patient's going to be kind of protected, as quickly as 2 or 4 hours after they take the medication. 2 examples: Rivaroxaban, which is Xarelto. Xarelto, is one that has, again, very few drug interactions and is not affected by any type of, food or any outside influence. Does have, good treatment protocols and FDA approved, guidelines for VTE prophylaxis. So, 10 milligrams, and this is kind of what, is approved as 10 milligrams once daily, can be started as early as 6 to 10 hours after surgery. I'm not saying you have to do that. It could be 24 hours if you want to give the patient, time to, to coagulate before you start it, but knowing that once it's started, pretty quickly on it is being used effectively. For hips and knees, it's anywhere between 12 and 35 days. I'll get into, my opinion for foot and ankle surgery at the very end here. And then for DVT or PE treatment, again, patient of mine personally who had a superficial venous thrombosis in her lateral leg, and we treated her anticoagulator. She started on this protocol, 15 milligrams, 15 milligrams twice a day for 21 days, and then 20 milligrams, it was for 3 to 6 months. Basically, working with my cardiology colleagues, we re-imaged the clot at 3 months, and it had dissipated. So she was able to stop it at 3 months. If it was still present and symptomatic, would have gone on for another 6 months. If it's still there after that, and sometimes it comes to a factor of being on it for the rest of your life. Eliquis, another medication, similarly, to Xarelto, again, a factor Xa inhibitor. As far as dosages go, This would be a smaller amount of medication, 2.5 milligrams, given twice a day. And then for treatment, 10 milligrams twice a day for 7 days, then 5 milligrams twice a day for 3 to 6 months. Again, looking at imaging or what type of VTE it is as far as treatment goes. One thing I like to point out, looking at side effects of some of these medicines, obviously, there was a significant risk of, this is a systemic review looking at using some of these medicines across, 43 random controlled trials. One thing where they saw an increased risk was in GI bleeding. When a patient kind of goes on these medicines, though, sometimes when they're being treated for a blood clot or for a PE, the kind of the Read the Riot Act by the doctor that's putting them on it. In fact, my patient that I had with the bilateral PEs, when she was started on Eliquis, she was very upset, and I said, "Well, what's the problem?" She said, "I may never be able to travel again." And I said, "Well, why?" And he said, "Well, what he was more worried about was not me getting another blood clot, but turbulence." He told me that if you're on a plane and it's turbulent and you hit your head, now you're in the air and you could have a subdural hematoma because you're at high risk of bleeding. So it's interesting when we're protecting these patients afterwards, and sometimes you have a patient, maybe you're anticoagulating, and they ask if they can travel, or they ask if they can go and do certain things, and you're thinking in the back of your mind, yeah, you can, because I'm anticoagulating you, you're not going to get a blood clot, but you could fall down and hit your head, and now you have another problem. So you kind of look at have to look at the whole picture of what you're doing with your patient as far as the risks that come along with some of these medications. So bleeding is certainly a big one. In summary, between the three, the only thing that really kind of, they all have very, like I said, very quick acting plasma concentration times, very quick half-lives. So they all, if you have someone that's bleeding, you can certainly, or has an issue, they can stop the medication. There's no need for reversal strategies like fresh frozen plasma or vitamin K, like with Coumadin. Just stop the medication, and then within 24 hours, it should be completely filtered out. The only one that I think is one where you'd pick one over the other is if you have a patient with a history of chronic kidney disease, or they have some, type of, kidney injury. Eliquis seems to be a little bit better as far as its excretion goes, and you don't have to dose it as differently. Sometimes we have to decrease some of the doses of Redaxel or Xarelto if the patient has a history of underlying high creatinine or kidney disease. With Eliquis, you don't have to do that. So how long should we treat a patient, after surgery? My general guideline is as long as the extremity is immobilized. And what I mean by that is that usually if I have a patient in a cast and they have the risk factors and I'm going to, do VTE prophylaxis, as long as they're in that cast, that's when they're getting the medicine. So if it's 6 weeks, it's 6 weeks. If they're in cast for 8 weeks, my triple patients are usually in a cast for between 6 and 8 weeks. They're being immobilized, or they're being prophylaxed for, whether it's 60 days or 42 days, because the limb's just not moving. And a lot of times patients are, sitting at home, during those periods of time. If they're weight bearing, if they have a cam walker boot and they can take their leg out of it and they can move their leg back and forth, well, then it may only be as little as 10 to 14 days or 12 days afterwards. Then I start getting them moving around at their second post-op appointment. Even if they're non-weight bearing and they're on crutches and they're in a cam boot, that's fine too. They can take their foot out of the cam boot, a few times a day, do some, calf muscle exercises. They can put on and off usually, TED hose, or even use, compression, device on their calf. And so those are ways to mechanically prophylax them too, so you can stop the medication. So I think just as a general guideline, and this may be debated, but I think if they're immobilized and sedentary, you keep them on the medication and keep them protected. So final considerations, obviously, with understanding these medications, it's good to understand our process of hemostasis, understanding the science behind developing a blood clot and VTE prophylaxis. Familiarize yourself with your hospital or surgery center's EROS protocol. Sometimes this comes into play. As these newer medicines can be very expensive, especially if you're going to treat a VT or PE. You can do what I did and marry a pharmacist, and she'll help you out with that. Or you can, Google support Eliquis, 360 support Eliquis, or pay for Xarelto. Brings you to websites that can pull up copay cards depending on the patient's commercial insurance. They may, pay for one or not the other. So it's a very difficult thing to navigate, but sometimes this is just an easy way to give patients some information ahead of time. Make sure you're keeping in close contact with your cardiology and internal medicine teams so that everyone's on the same page as far as perioperative management. Don't be a weenie with a high Caprini. That's my my little slogan. If a patient has a high risk score, then really consider prophylaxing them. So doing that ahead of time kind of helps you prepare for the case. And again, with the factor Xa and direct thrombin inhibitors, if you're going to immobilize or if you're going to treat the patient for prophylaxis, do it for the duration of leg immobilization. So, thank you.